All right. Well, I guess we will go ahead and get started. I'm sure some people will kind of trickle in. I wanted to, first of all, just introduce myself as Dr. Michelle Dalton. I do go by Shelley. I'm now our incoming chair. So we'll be kind of trying to get everything in order for this semester so we can touch base. So I'll drop an agenda. Patricia, do you want to go ahead and introduce yourself as well?
Yes, I'm Dr. Patricia Huerta. I am a faculty member over at East Carolina University in the Department of Family Medicine, and I'm the secretary.
Fantastic. And for the two others on the call, do you want to introduce yourselves too?
Yeah. Hi, good morning. I'm Dave Haddock. I'm now retired, but formerly head of a company that built technology to help implement integrated behavioral health care.
Fantastic. Thank you.
I'm Sudhakar Kaushik. I'm a new member of CFHA and I joined when you all had your conference down here in Raleigh. I'm from Raleigh and I'm an engineer and we have a product that's directed at adolescents and young adults in behavioral health care deployed in California.
Well, fantastic. We're so happy to have you join us. So welcome. I do want to go ahead since we don't have everybody available on the call just to kind of put up a photo so you can kind of see who our other incoming leaders are. So Dr. Heifner, Angela, she is our past chair. She's currently out on maternity leave, but will be joining. Misty Schmidt is our chair-elect, so she will be next year's incoming chair. She was previously our secretary. She's running a little bit late. And then Federico Mendez couldn't be here today. He's our early career professional. And he is wrapping up his PhD at Texas Women's University. That way y'all kind of have some faces, and then if any of them are able to pop on, then we'll just have them go ahead and add anything else that they would like to add to. Okay, so a little bit about what I thought we could kind of talk about. I first just wanted to touch base on the conference and see if there were any lingering thoughts or reactions or things that went well at the conference that y'all wanted to kind of touch base on. I myself did not have a chance to attend, unfortunately.
Sorry, it just seems like so long ago now.
I know there's always kind of that little bit of gap between when we have that and then we kind of return back for the start of the year.
Yeah. I attended it and I thoroughly enjoyed the conference. I thought it was one of the best we've had. And I guess I've been a member for 6 or 7 years, so I've been to a few of them.
It was my first experience and I thought it was just fabulous. I just thought there was not enough time to take in all the things that were happening and there were parallel meetings and
Yeah.
there were no recordings either to catch up on. So that was a little bit of a um, for me. There was a little bit of a gap that I couldn't catch up on everything that was going on. But I'm trying to come up to speed as a non-clinician, as an engineer, trying to see where tech can always play a role in integrating behavioral health into primary care settings and such, and including because we have a project going on in Florida as we speak to try to get something done for PCPs at the front line. And so very interested to be plugged in and understand clinicians' perspective on all of this and how you all do it.
Yeah, I think it can be really challenging, especially as a non-clinician. I think a lot of conferences tend to have like these multi-tracks, but certainly it can be a little overwhelming when you're coming in, particularly when there are not recordings. For us, with kind of having the family SIG, we usually have kind of a separate track where some of our people might go through that for like certain certificates of completion, et cetera.
Hmm.
And it sounds like for you, David, you mentioned like you'd been there 6 or 7 times and you said this was one of the best. What do you think made it really stand out?
That's what I'm trying to put my finger on right now. Um, I agree with Sundakar that the overlap in sessions is a frustration. That I have no idea how to overcome that because there's so much material that needs to be presented in a short time. I participate in the measurement-based care work group and the value-based payment work group. And so um, those meetings, those meetings at 7 in the morning were very, very useful.
Yeah, it sounds like having those meetings. I know for our SIG, sometimes we run into some issues where we might have people that are on overlapping committees. So finding times where people can attend both, I think might have been some of the challenge I had heard back from others.
Yeah.
Now, this year, the conference will actually be in St. Louis, which is actually where I'm located. So I know one of the things that leadership was hoping to kind of do is just maybe discussion of maybe what we would like to see from a family's perspective as we're moving into this. I know one of the things that had been kind of called for from the meeting at the conference was how can we get more poster submissions that are family focused. One of the things we talked about as a leadership team, for example, was how can we really center students, particularly like PhD students who are going to be moving into that leadership role, or even more advanced master's students. And I know Patricia and Misty and I were kind of working on putting together like a listserv of some of the MFT and other related programs where we might be able to kind of reach out and encourage submissions. I know on a St. Louis University side, we are strongly encouraging our students as well as kind of helping them prepare some of the proposals. So I do think we'll see that. But I know SLU's expectation is that we are kind of there to help some of these students and capture them. So I think we would like to have some sort of dinner one of the nights of the conference in St. Louis, kind of hosted with SLU. Just that way we can kind of get to know and maybe form some more connections. I think the conference being so much more affordable for students makes it kind of an easy way to get their buy-in into CFHA and also to show the value of the SIG. And I think like that advanced mentoring, especially having people from different areas of their career within our SIG, is such just a useful thing in terms of mentoring relationships. So one of the major charges I would like to see at the conference is just more student involvement. I don't know if anyone else had any thoughts about other things they would like to see.
Um, I just looked back in my notes, and one of the highlights for me was the extended learning opportunity put on by Sandy Blount. Sandy Blunt. It was just like a wrap up of 30 years of progress in integrating behavioral health care.
I'd heard really good feedback about that session in general. Patricia, did you hear anything else about that one?
I didn't. No, I didn't hear anything about that session. I did have just kind of one idea or thought that just formed. Um, I'm part of one of the marriage and family therapy Facebook pages, and someone recently posted about declining rates of MFTs pursuing PhD programs and pursuing doctorates in general, and why that may be. And there were some like people were giving feedback as to why they hadn't pursued a PhD. So I'm wondering if there's some way that we can include that conversation, that discussion to some, in some way, shape, or form. Because it does seem like it's a trend within the field and something that if we could get ahead of and maybe, like you were saying, like increase student participation, engagement, maybe we could stop the bleed, so to speak.
Yeah, I think that's a great idea. And Misty, thank you so much for joining us. We're just kind of touching base on maybe some of the things for feedback in terms of what we can do for the conference. And Patricia was just sharing that we're kind of seeing a declining rate of MFTs wanting to pursue PhD. I think this is such a unique area with you, especially like moving out of that role and being in that early career and kind of moving more now into a new position. So I don't know if you're familiar with everyone on the call, but if you want to introduce yourself and then we can kind of resume where we're at with the conversation.
Yeah, I'm Misty Schmidt. As Shelley was saying, I just completed my doctorate at TWU. I will be moving into a position actually at St. Mary's Family Medicine program, residency program, shortly. And so what's interesting is I just did an interview, which will be coming out in the newsletter around this, around PhD students going into integrated care and MFTs in this field. So yeah, it'll be just interesting to see that perspective looking forward in the newsletter. But yes, I'm Misty Schmidt. I look forward to being on this leadership team, and I look forward to the webinars and anything that we can bring to the Family Health SIG. So thanks for having me.
Thanks, Misty. I think one of the things is maybe a misunderstanding that I've seen out in the field about different career trajectories. I do think there are some PhD programs that are very heavy into research, and there are some that are more heavy clinical. So in the MedFT world, like St. Louis University and ECU definitely have like two of the more medical PhD programs. And so I think especially having faculty in the SIG from these universities opens up an opportunity where maybe we can talk about, and maybe that might be like a student-focused webinar we could do, might be like, PhD options in the field, or maybe even just a breakout talk at the conference. But I think some more support in addition to what Misty is already putting into the newsletter to really focus. Because I think back to when I was a beginning clinician in my master's program, and I used to jokingly say you couldn't pay me to go for a PhD. And now here I am, obviously at the PhD level. So I think sometimes students don't really realize maybe how a PhD could open up their career opportunities, not just in terms of like a full academic route, but being like a clinic director or teaching in a medical school, and kind of how you can do so much of that collaboration in terms of like program eval. So I think we have a lot of opportunities. And even within our newsletter, we had also talked about trying to feature like a PhD student every time we release the newsletter, just to kind of like put more of that support. So then maybe master students that are attending can also kind of see like, what are PhD students actually doing, right? Because they might not know maybe how the SIG or even just CFHA as a whole might be help support that pathway too. So I think those were some of the same things it sounds like, Patricia, were really echoed in what you were seeing in this group too. If anyone else had any other thoughts.
Well, I know part of the plan, and I don't know if you had already touched on this already, either of you, but part of our plan going forward is connecting more with the different programs, the MedFT programs, the MFT programs going forward, and just keeping them, considering what CFHA offers, getting more of their master students involved in what we do so that they can see there are other opportunities as a MFT in the field. And so, yeah, I think some of the plans that we have going forward, connecting more with these different programs, universities, being able to kind of have that almost like mentorship type experience for these younger students or their master's level students to see the opportunities that we do have going forward. I know as a supervisor, even working with students in the master's program, they're not really aware of what opportunities are out there unless somebody does kind of offer that. They more look at the private practice route or community mental health. But as somebody who supervised, I've worked myself in school settings and MedFT settings, different settings that they weren't even aware of. And so I think this is a great opportunity for us to be able to share what that looks like. But also then we have job opportunities available through CFHA that's how I found my position. So I think it's a great opportunity for us to help master students into seeing what a PhD can do for them and CFHA.
Yeah, I love what you brought up too about as we're partnering with these other programs. I know one of the things that we've been doing at SLU is actually having like the MedFT Summit be like something that's kind of like built into coursework. So we've been kind of trying to find ways to get students to just even get their feet wet a little bit in terms of like what we actually have and connecting that. Because the hope would be that CFHA, we're kind of helping take the load off of some of this clinical training that then doesn't need to be as embedded into some of these programs, right? So being able to say, oh, we have workshops on these different things, I think can be extremely helpful for reducing that load. So one of the ways that I think that we could kind of get more buy-in might be to invite faculty or adjunct faculty or maybe advanced doctoral students that have extensive experience to present from these different programs, because then they'll obviously be snowballing that within their program as well. And I think that can kind of help partner to show that we really are trying to help support them as much as they're trying to help support us. I know one of the speakers that we've looked into for Lizzie to potentially be our first speaker of the year in February She was also kind of moving into doing her PhD right now. I believe she's in, is it Georgia? Is that where she's
Virginia
at?
Tech.
Virginia.
Virginia.
So she's at Virginia. So again, I think these are really great ways to kind of get buy-in from faculty or PhD students at these universities. So that would be some of my thought is just involving more involvement, which I think also spreads out our speakers. So like last year, we had a speaker from family and community medicine here with Dr. Kento from SLU. And that kind of got more of an awareness of CFHA just even in our overall department too.
So can I ask a slightly different question? And more from the perspective of an outsider looking in. Okay. I see Misty nodding, so I'm taking that as an yes. You're all muted. But what is in the back of my mind is what would you think from a real clinical setting perspective, from a real industry, if you will, service industry setting, the family health and community mental health that Misty was bringing up, those kinds of things. Where might be the challenges that continue to persist structurally in terms of driving outcomes, driving access, driving improvements in how patients engage and get services? And I'm obviously interested more from where can we apply our technologies to be able to solve those problems. And I'm curious to understand from the actual clinicians and practitioners' perspective in terms of what they see as the real problem from their perspective that they could use technologies for. So back in the day when NSF used to be operational, and right now it's taken a hiatus, National Science Foundation, we used to be able to interview practitioners for the purpose of actually putting in a proposal. And that was something that we were working on, and then it's gone on hold because everything's frozen. NIH and NSF is all frozen. But this may be a perfect time, if I were to think about it, to actually try to build up that sort of a knowledge base for me to be able to really see if there is anything that we could do to help both patients and clinicians. Any thoughts on that? And I'm happy to do offline interviews and such too, but I don't know if there are speakers that can talk to it. There are, as you're thinking through it, as you're brainstorming it, I thought maybe I'll just pipe in if that's okay.
I think one of the things that I've heard kind of not just within CFHA, but I'm also a member of the American Society for Addiction Medicine, and they have kind of like a behavioral health group there. One of the things that they had said was a limitation of technology is just when we're looking at EHRs or even intake processes that are developed, say, within these large community-based centers, is that getting data from more than just the individual patient tends to be a challenge. Right. So even on therapist EHR systems such as like Theranest or Simple Practice can be a little bit cumbersome to like collect information. So I think that would be likely one of the pathways that I've seen people just really frustrated about. So anything that I'm sure there's many people that would have more info on that, but that seems to be a common complaint. It's just how to collect dyadic data.
Yes. I was in a call yesterday and South Carolina Community Health. Chandra Beasley, you folks might have heard of her. She was bringing that point up as well, and we were talking about interoperability standards and how EHR plays dirty in not sharing the data. And, and there's Dr. Patricia nodding her head along. Yeah, that's absolutely right. So yeah, curious if there are ways that we can actually do that in a systematic way too, if that's possible. I think that is the patient engagement data is also something that CMS is pushing for now under the access model and tempo. So outcomes driven, outcomes tracking. So we have all of those from a behavioral health perspective, and we are struggling with being able to bring the data and put it into EHR because we cannot get write permissions. We can get only view permissions. And what we had proposed to the PCPs in Florida was that we should be able to, well, it would be a cumbersome thing for the PCPs, which is we would effectively stand alone we would do a standalone service where we would actually do the analytics from our side, collecting it from mobile and wearables and push that through. But they have to do the matching from AHR medical records perspective. But we can take medical record one at a time and try to see what we can do. But that's a limitation, absolutely running into that.
Yeah, I think that has been kind of one of the overall limitations, especially for systems like Epic, where it's just like it's difficult to get a lot of data through. I think it's a worthwhile conversation to keep having. I'm just not sure I have much that I can personally add, just kind of echoing the fellow frustrations.
Correct. Understand.
I think kind of another idea on not related necessarily to the EHR, our practice, we operate in eastern rural North Carolina, and I can imagine we are facing similar challenges that many other places are, in that there is a much larger patient need than realistically there are providers.
Yes.
That's true for any profession, and I think marriage and family therapy and the people that have kind of the skills or the additional training to do more of that systemic family couple work are in a lot of ways the minority, right? Compared to like clinical psychologists, who I supervise a bunch of clinical psychologists here, students, and they want nothing to do with more than one person in the room. That almost makes them break out in hives. And so I think one of the challenges is workforce development. One of the challenges is burnout, right? When you have that constant patient need, it can feel easier to burn out realistically. I know that the PCPs here are trialing like a AI dictation software, they bring their
Driving.
phone into the session, and then the AI essentially like transcribes and writes their notes in order to reduce some of that documentation burnout. There are, at least at our site, hesitancies to include behavioral health within that process, because there are fears about patient interest due to the sensitivity of the information we talk about, and just where is that information stored, just lots of understandable hesitancies and cautions. So I think if there is a way that AI could somehow like help us almost clone ourselves to be able to meet that greater patient need without relying on AI to be therapists and to do the
Yes.
therapy, because unfortunately we've already seen some adolescent deaths from suicide as a result of like using ChatGPT as their therapist. But essentially help us broaden and extend our reach, and then increase workforce development and reduce, I would say, burnout, and related specifically to documentation and like administrative pieces.
Perfect.
I think there's some major challenges with AI. I work with, a large LGBTQ neurodivergent population that I know those patients would not go to providers that were using those tools and have a lot of hesitancies. I know here in Missouri, we had issues where like certain people's medical records were being passed over to the state. So I do think like there are a lot of benefits to using AI, but I also feel like on the patient side, there's a lot of hesitancies. And I think it is really trying to kind of ride that line of like what can help providers, but also patients, because I think individual providers cannot really provide that same level of confidentiality that maybe we felt like we could in the past, given everything that's happening. And as we're kind of talking through this, it's kind of making me think that going back to the earlier recommendation, maybe we should really have like an AI and families kind of webinar or something of the sort to maybe address, even just to create some community conversation around this or what we're seeing. Since this does seem to be such a timely topic, I don't know how others would feel about maybe recruiting someone for a webinar for that.
I do want to mention an experience I've had the last couple of weeks. I'm used to my primary care doctors at Kaiser typing furiously on their keyboard while looking over their shoulder to talk to me. I had to go in for a visit when my regular doctor wasn't available, and the doctor I saw said, "By the way, I'm using a recording service to generate my notes." His shoulders were square to me. He looked me in the face the whole time. It was a productive visit. And later on, I went to my chart and looked at his notes, and his notes were almost perfectly accurate and detailed. And he never touched a keyboard the whole time. So in that situation, I think AI is in the background. You really don't know what it's doing. There have been scribe services for years. They've even hired people to act as scribes to do the work to unload the doctor from that drudgery. Anyway, it worked. It worked seamlessly, and it was quite accurate. Um, there's just one little mistake. It mistook the medicine Asmonex for aspirin. So I called it aspirin instead of Asmonex. But that was the only error, and he wouldn't even picked up that. He would not even pick that up on proofreading. So anyway, that was a good experience. But I do want to mention a slightly different perspective here. In the PCBH model, it's a short visit. There's not a lot of time to make notes, to record, or to make measurements and record measurements. And yet, in the value-based payment world, we have to have outcome measures. And the only real valid outcome measures are a combination of behavioral health and medical care, because we're trying to make the medical care more effective. We're trying to keep patients using their medicines more accurately and more consistently. We're trying to overcome problems that they have which are causing ill health. And you can't only measure behavioral health visits and get that whole picture. So we have to have the ability to aggregate the data between the behavioral health visits and the patient's medical outcomes. And if we don't do that, then the ability to justify behavioral health and PCBH will be diminished because the value won't be measured, and if it's not measured, can't be managed or reimbursed. So that's my concern.
Yeah. Dr. Patricia, you said East Carolina University? Is that where you are? You said?
Yes. Yep. I'm part of
Oh,
the family medicine department here.
okay. I am actually working with somebody there for workforce development. We just submitted, yeah, we just submitted something for the Federal Register grant because our workforce development would do some of the things that you were talking about. I didn't, Dr. CG Dominic Clements.
The
She's
name
in the,
sounds a
yeah.
little familiar.
I,
The grant that actually funds my position here is a HRSA grant, and it is really focused on like workforce development, increasing access to care.
I didn't know there were other people doing workforce development there. Okay.
Yes, yes, and
Maybe.
I think both like the behavioral health world, we desperately need more providers
Right.
in workforce development. And, what I hear my medical colleagues talking about is, right, like reduced admissions rates or, fewer people seeking out medical school. And now with the potential limits on the amount of money you can take out in loans, that becomes even more difficult or even inaccessible unless you come from a wealthier background. So
Okay.
it's becoming increasingly challenging to do something that we know we need to do.
Right. Okay. I don't want to turn this into a pitch session, but I will follow up because
Yeah.
knowing that there is a gap, knowing there is a need is wonderful. That's what I would like to get into and dig into. And Dr. Shelley, you were talking earlier about an AI session. We just got off a session that was a community discussion that CFHA put on. I was in the panel just, 20 minutes ago. I mean, just as we got on this call. And the whole idea there was, I think there was an East Carolina student who was looking for getting into the tech side of behavioral health as well. So that's very interesting. So there is a groundswell, in my view. Obviously, I'm biased for AI and tech and the role that it has. But if there were to be a discussion on that, I think that would be pretty wonderful because I think there are I'm of the view that it can be a wonderful tool if it's used properly and constrained tightly, um, not allowed to make independent decisions, clearly. There's no question about that. And I think I spent 20 minutes talking on that other call about, I was one of the panelists, I was one of the participants, super participants, as they call it. And I spent considerable amount of time trying to talk about the fact that ultimately it comes down to the core expertise of the clinician that we have to depend on to be able to really provide an enhanced level of service and outcome. And that's not going to happen without the core expertise that comes from the clinician because by definition, engineering work is very deterministic. Input translates into some factor and output. And we don't make that judgment. We cannot because we're just fundamentally constrained there. And that judgment call, that diagnosis, that comes from expertise and experience.
Yeah, it sounds like in general, like some sort of topic focused on AI or tech and how that might kind of help our role seems like it might be a good webinar topic. I know Patricia has put together a survey that has some potential other webinar topics. Patricia, if you have that link, you can drop it or we can put it into the base camp. But I'd also like to see if there are just any other topics related to families and health that might be relevant. Again, one that we're kind of in the middle of seeing if we can get her booked would be Lizzie Love to talk about couples and integrated care in February. Misty, I was trying to nail down the date. I think I might have lost the date for that one, but it looked like at 3 p.m. Central was kind of their proposed time.
That's correct. I believe it was February 25th. Let me double check.
The 25th sounds kind of familiar.
Yes, the 25th.
Okay, so that would be our next proposed webinar time. But if there are any other webinar topics that y'all would like to talk through, I know Andrew, you just had a chance to join us, and I'd love for you to have a chance to introduce yourself as well. But I think that might be helpful for us to kind of figure out where to go from here and what might be of interest to the SIG, rather than us just informally sending out the survey. We wanted to give people some airtime. So Andrew, if you want to go ahead and introduce yourself, and then we can kind of as a group chat through maybe other webinar topics.
Yeah, thanks for the opportunity. Andrew Jensen, I'm a licensed marriage and family therapy associate. Just recently moved to Asheville to work with Kyle Gillette, who's running a program at Mission Hospital. It's actually contracted. We're a contracted group into Mission Hospital. Healing Hearts is the group. And I was trained into medical family therapy. So that's kind of my lens on things. I was loving the conversation. I missed if it was Dr. Haddock or David. That I think that is a big thing that I keep bumping up against is like, can we keep speaking the language of data and showing that like that we're relevant. And also I think this conversation about AI, particularly for me, I think we're moving towards patients taking more responsibility for their care, which is a huge task. And I think if patients could really effectively use AI to support that, like having the simplified answers, but also bringing that to their care team. So just a few thoughts on that, but that's where I'm at, who I am.
Well, thank you so much for introducing yourself. It sounds like also some interest in AI. I want to kind of open it up if there are any other webinar topics or speakers that y'all might be interested in just off the top of your head. Since we'd kind of hope to have at least 4 webinars, so that might cover 2 of our 4, leaving 2 open for health and family related topics.
Can I chime in with another thought as well? One of the things that we are trying to do with this PCP project, with PCPs and they're all small PCPs, so they're not having to have an EHR for the same reason that I was talking about, which is the challenge. So the independent PCPs in Florida, rural part of Florida, but they have a consult going on down in Greenville, I think Greensville, Florida, which is the hub where University of Florida Hospital is and the psychiatrists are. whereas this is the rural unit and they do a consult. So anyway, one of the things that we were toying with there is the inclination, the interest that the families would have to be able to screen for substance right at the primary. The premise being that, especially that population, which is predominantly Hispanic, and culturally they go to an ER rather than bring up anything to a family physician or to a therapist. They don't seek out a therapist. And so the thought there was we don't catch some of these issues until it's too late. And if you were to do the screening in the primary, because everybody does go have at least one screening, though fact of the matter is more people spend more time with the therapist than they would with the physician if they were to have a diagnosis. But here is a case of they wouldn't really show up in a therapist's office until it's too late. So can we really do the screening? And doing screening, would that be amenable for for that particular population? Would the parents be okay with it? How do we manage it? Those are all discussions that we are trying to do the thought experiment without any expertise. Right? We're not, we don't, I mean, I'm an engineer. I don't have the kind of clinical background that you all have. But I'm pushing back on the psychiatrists saying that who are down in Greensville. I keep getting mixed up. I'm in Carolina. They're in Florida. But there, the challenge is they assume that they should be able to screen, and I'm thinking from a patient perspective, how is that experience going to go through? What is the consent process going to look like? What is the are the parents going to be? Because we are running an adolescent and young adult project in California, and we are having to take consent at two levels. And Florida requires pediatric services screening both by the parent as well as by the patients if they are sub 18. So we are trying to figure out if substance can be screened for, and would that allow us to be able to intervene earlier, or at least introduce psych ed modules to be able to really make the children comfortable, make the parents comfortable to be able to go seek out help and so on. So those are some of the things. I don't know if that can be molded into a topic per se, but doing a substance screening early when you're 10, 12, 13, 14, versus when you really have started to take the habit into a higher gear. And now we are talking about rehab, we are talking about weaning. So it's a different dimension of the problem.
Yeah, this is actually one of my areas of specialization is substance use disorders. And I will say that there are so many pros and cons to doing like a screening versus a clinical interview. And in my experience, I find that adolescents are not very likely to be very honest on these measures. And that you have a lot more of I would say, a fair shot at getting an accurate assessment if this is done by a trained clinician, preferably somebody who has some rapport. So where I will have adolescents come to me and be like, yeah, I was screened out my psychiatrist or my GP and I just straight up lied because I knew they were going to tell my parents. So I don't think it's as simple as saying like, can we catch them early by giving a standardized measure? I really do think it should be a combination of clinical interview. Even at a minimum for the therapist to say like, hey, I noticed you didn't check anything off here. I just wanted to touch base, something like that. But in my experience, like adults, you're more likely to get maybe more accurate through standardized tools. But otherwise, I do think you'd be looking at training someone even to, verbally give something like an audit or Cupid kind of screening, something like that. But there needs to be a rapport if you want accurate answers.
I just want to mention from my experience that adolescents are more likely to respond accurately to a computerized survey than they are to a person. Looking at a person and trying to tell them something private is difficult. They're much more comfortable working on their phones and telling the world all their problems on their phone. So my company built a system for communicating assessment tools directly through the smartphone. No portal required, no login required. It's pretty successful in that sense. Can I mention one other thing before we run out of time? There's another confounding factor when we try to look at population health measures to justify PCBH or to measure the contribution of PCBH to physical health and therefore the cost of care and outcomes. There's an equity issue. who gets into PCBH. Now, if everything were equal, then we could look at the people who had behavioral health interventions and their outcomes versus those who didn't have behavioral health interventions and their outcomes, and we could say, yeah, behavioral health saved this much money. Problem is, those populations aren't the same. The populations that don't get into behavioral health care in a primary care office are largely people who don't have the same ethnicity, the same culture, the same language as the clinicians or the primary care doctors doing the warm handoff. So there's a huge equity issue there that really confounds all of our data. And I'm speaking as somebody on the West Coast, where in the cities I live in and work in, there are 50 some languages spoken at home. And so it takes a great deal of effort to overcome those language and cultural barriers to get people into a behavioral health consultant. So that's another issue that needs to be addressed in order to have valid population health measures.
Yeah, I agree. And I think this is a very, very important topic, especially given everything in the socio-political climate and how that might be influencing the kinds of both patients that are, using some of these resources, but also the cultural background or the socio-demographic variables of the actual behavioral health consultants working in those settings, particularly since many of those positions are oftentimes underpaid as well. So I think there's so many important things, and I think this would always be a very timely topic that we could include in a webinar. I know we're kind of coming up on time, so I want to just make sure to hit on some of these other things too. And then if we have time left, we can kind of circle back to more of the webinar, or y'all can also put in your feedback via the survey that Patricia dropped. Just as a quick update, we will have tomorrow the family-centered care working group, which is already kind of established. So we're going to pick up, and some of the things that we're looking at are where are we going to be submitting these. So we have some policy recommendations, some payer recommendations, clinicians, etc. I'm currently working with Hannah and Naftali to figure out our best course of action for how we're going to deliver these. But our next steps are largely just standardizing all of our templates since we have them written up. And we were invited to potentially submit that to a journal as well. So we have to kind of just see how CFHA would like us to kind of frame these recommendations, and if these recommendations are meant internal for CFHA or external. So tomorrow's working group meeting that I'll be leading, we'll kind of talk about that. And then just as a quick shameless plug, one of the ways that we thought would be helpful to kind of grow awareness of our webinars as the SIG and also of CFHA as a whole is to have more of a social media presence. I think particularly when we're thinking about like recruiting master's and PhD students in early career, I think anything we can do to really engage in social media will be helpful. Misty's been kind of spearheading that and has dropped our Instagram. So we will be featuring like our different leadership people there. We'll also be featuring any of our webinars, as well as like our meet the clinicians or our like students that we'll be interviewing as well. So if there are any other content recommendations, please feel free to send those over to Misty since she's kind of spearheading that. Or if you have any other thoughts about maybe how we can implement social media to kind of reach more of that younger generation who maybe is using it more than, maybe just a basic email listserv. I think if we're going to want to stay relevant, particularly as technology is evolving, we want to make sure we're kind of speaking the language of our members too. So I don't know if anyone had any initial thoughts or feedback about social media.
Our apps that we rolled out for CYBHA in California, the Child and Youth Behavioral Health Initiative. It's really for ages 14 through 24. And one of the things that we find is, and that kind of corroborates with what David was saying earlier. I don't know if it's Dr. David, sorry. But
Dave.
Dave, so they tend to actually do a lot of journals late night. They tend to when they're doing the journals, they're also looking at TikTok. They're also looking at influences, and then there is a little bit of self-diagnosis that's going on, and the whole reason that we put down, and Dr. Patricia is nodding her head vigorously there. The whole reason we tried that experiment for journaling alongside whatever else that they were helping with is to be able to really try to surface those things that they had as a habit, which is who do you turn to? And what we are trying to find, what we are finding is increasingly ChatGPT is now taking the place of social media, in the sense that they are consulting a ChatGPT or something similar to that. Could be it's not OpenAI, it's Cloud, but they're coming in with semi-diagnosis, and they're coming in with the prompts that ChatGPT is asking them to actually ask their therapist. So there is a family therapy practice that we partner with in California. We're just a supplier of that tech, and what she's finding out is, or what she's asking us to do, is to see if we could actually help her to be able to really understand how to respond to these kinds of things, and which is both give her ammunition in terms of what the limitations of the tech is, as well as help her to be able to anticipate some of these questions, which has now added more burden to her, if you will, because she's now having to justify whatever she's doing is right. She's now having to explain that what she thinks, because more than likely the ChatGPT is encouraging and being more positive and being actually very solicitous, or being very almost obsequious is probably the word I'm looking for, which is it's going to try to please the users. So the patients are coming in with expectations that are way different than what a therapist would say, and that's been her challenge. So I'm not saying that social media is irrelevant. I think it still is, but I think there is a new beast in play.
I agree, and that's kind of making me think that maybe another potential webinar topic could be, how do therapists and families respond to adolescents using things like ChatGPT? What does that look like in the therapy room? How do you bring that up? How can parents address it? It could potentially be a single speaker or a panel, but I think this is quite different from our other AI conversation, which is more directed towards clinicians, kind of
Right.
on the back end, versus something like this, where it's like maybe that's more of that clinical topic that bridges maybe that research tech academic world with clinical practice. And seems like it'd be extremely timely, especially since it affects mental health, things like, like AI psychosis, as well as like
Yeah.
where are they
Yeah.
getting health information.
Yeah. I think I saw somebody characterize that as a suicide coach. Um, I think that was actually Salesforce CEO making that comment. I mean, obviously, he's saying it to be able to do what he can to diss AI, but that's a different issue. That's not the point. But I think that is a good risk of AI being there.
Anything else related to social media? That was kind of the last thing that I had, other than just continuing to follow up with our next webinar will be scheduled. Then we'll be sending that out to make sure that we have enough availability and interest for the 25th of February at 3 p.m. Central with Lizzie. And then from there, we'll be able to kind of schedule. So if anybody has any recommendations for speakers, to put them into that Qualtrics survey, or you can actually just email them directly to myself and Patricia, since we'll be overseeing that. Because those were kind of the last things that I had. If anyone else had anything they wanted to add or talk about in our last few minutes.
Pardon me, what was that date again in February?
February 25th. Which looks like that is a Wednesday, so it'd be a Wednesday at 3 p.m. Central.
I'm sorry, what is the topic that you said was going to be covered?
It'll be couples in integrated care.
Okay. And policy recommendations, if I remember.
Yep.
Okay.
Anything else anyone has before we break?
Dr. Patricia, I put a DM if that's okay with you.
Okay, well, if anybody needs anything else, please don't hesitate to reach out. And again, thank you so much for just stopping by and kind of sharing your thoughts. And then if there's anything else that we can do to be helpful as a SIG as we're kind of transitioning in, the webinar we'll get info on that, and then the newsletter will be released within the next week. So you'll also have a copy of that. But if you need any other support, please don't hesitate to reach out to leadership. We're happy to help support and kind of advance the overall SIG agenda. All right, well, take care, everyone. Thank you so much.
Thank you very much.
Yeah,
Bye-bye.
bye, everybody.